सर्वे भवन्तु सुखिनः
सर्वे भवन्तु सुखिनः
सर्वे सन्तु निरामया
सर्वे सन्तु निरामया
सर्वे भद्राणि पश्यन्तु
सर्वे भद्राणि पश्यन्तु
मा कश्चित् दुःखभाग् भवेत्
मा कश्चित् दुःखभाग् भवेत्
न त्वहं कामये राज्यं
न त्वमे कामे राज्यं
न स्वर्गं न पुनर्भवम्
न स्वर्गं न पुनर्भवम्
कामये दुःखताप्तानां
कामे दुःखताप्तानां
प्राणिनाम् आर्तिनाशनम्
प्राणिनाम् आर्तिनाशनम्।
Thank you so much.
Dignitaries present, the two guests of honor, the distinguished speakers, and my distinguished colleagues. First of all, let me convey my heartfelt gratitude for allowing me to be present on this auspicious occasion. Well, I haven't been here, I haven't been a part of GP Association, and one of the advantages of attending this meet that I have renewed my acquaintances with many other colleagues, or many of the local colleagues that I was unacquainted with. Dr. Shahi has been very kind. He has, I heard his panegyrics are very, very nice to hear, but they may not be very accurate. He certainly raised your expectations. So in the process of raising the expectations, if I don't live up to those expectations, you'll know who to blame. It would have to be Dr. Shahi over here. It's very difficult to identify oneself when you are presented in such a manner. And I'm recalled, I just recall a particular evening, I've read about it, George Bernard Shaw in 1947, when he visited New York City, he was presented with a very, very panegyrating introduction, to which he responded by saying, "Well, that's wonderful. My father would have loved it, but my mother would have actually believed it." So probably my mother would actually believe all that, what has been said really, but my father would have been discreet enough, my late father would have been discreet enough to view that with a bit of circumspection. I know that you are waiting, perhaps, we are already behind time, so I know that you are waiting for the scientific session to start, and I'm hoping to learn quite a lot from that as well. But let me perhaps, so I won't take much of your time, I'll just say that I must compliment the GP Association. One of the things that you have to remember is that majority of the patients in India are seen by general practitioners. To hold an academic session of this nature serves as an excellent continuing medical education program. And perhaps, and medicine is not a specialty where updating can be dispensed with. You have to constantly update yourself, and that is absolutely necessary. You have to continue with that. As the chairman of the Standing Academic Committee, my endeavor is to involve all the colleagues in the academic activity and academic advancement of the All India Institute of Medical, local All India Institute of Medical Sciences. I'd like you to join over there for all the academic activities. You'll all be extended invitations. And plus, we are in the process of planning quite a lot of the CME programs where I would like you to be actively participating in all our endeavors. Well, perhaps, I'm myself looking forward to learn quite a lot. In fact, the hypothyroidism was a special interest of mine many years ago. And I'd like to know the different dimensions of the presentation of hypothyroid states. And I'm especially looking forward to Dr. Vinesh Mathur's talk on perhaps advances in treatment of spinal disorders, because that is something that we have all encountered. And one of my dismays after relocating to India was that there weren't that many facilities available. So that's something that we have to constantly update ourselves with. And as it is a convention, in fact, I usually have to end up with a joke. So, I'll end up with an actual anecdote over here. Many years ago, I was invited to address a conference in Turku, Finland. I had to speak on the research problems over there in London. I was in London at that time. So I indicated how difficult it was to find patients who had not been exposed to medications for research purposes. And patients who have actually not been exposed to medications are generally, in research terms, referred to as virgin patients. The very next day, one of my favorite possessions was a news item in the next morning's paper, which indicated Dr. Prasad, a psychiatrist from London, indicated that in central London, virgins are very hard to come by. Thank you.
Thanks. So I just want to. Thank you, Dr. S.P. Agrawal and Dr. P.C. Sai. जैसा कि हम सभी जानते हैं कि जीपी एसोसिएशन की जो CMEs हैं वो अपने आप में बहुत यूनिक हैं और इट इज़ बीइंग रेगुलरली बीइंग ऑर्गेनाइज्ड, दैट इज़ द मोस्ट इम्पॉर्टेंट थिंग. शायद IMA भी उतना नहीं कर पा रहा है जितना हमारा ये जीपी एसोसिएशन कर रहा है. जी नहीं, नंबर में मैम, आई वॉज टॉकिंग इन जस्ट नंबर्स. इट इज़ ऑल मंथली टू, तो डेफिनेटली इट इज़ अ वेरी गुड थिंग. और जैसा कि अभी हम सबके मुख्य अतिथि डॉक्टर अशोक जानवी प्रसाद ने बताया भी कि जो है हिंदुस्तान में सबसे ज़्यादा चिकित्सा जो है जीपीज़ द्वारा ही की जाती है. तो ये और इम्पॉर्टेंट हो जाता है कि अपने जीपी मेंबर्स को अपडेट रखने के लिए. और इस कार्यक्रम के विशिष्ट अतिथि डॉक्टर राम कुमार जायसवाल, लकली हम तीनों एक ही कॉलेज के प्रोडक्ट हैं. इट इज़ पर चांस एंड पीसी साई इज ऑल्सो हियर. तो लॉट ऑफ पर्सन्स आर देयर. तो इसमें आज कुछ कहने का कुछ बहुत अवसर नहीं है. बहुत सीनियर लोग बैठे हुए हैं और आपके जो व्याख्यान देने वाले हैं डॉक्टर विनीश माथुर एंड डॉक्टर दीपक गुप्ता एंड डॉक्टर कन्हैया अग्रवाल, मुझे पक्का विश्वास है कि जो है अपने सब्जेक्ट के साथ पूरी जस्टिस करेंगे, इसमें कहीं कोई शक नहीं है. और हम लोग आज वी विल एंजॉय ए गुड एकेडमिक फीस्ट. आप सबको बहुत प्रणाम करते हुए अपनी वाणी को विराम देता हूँ. धन्यवाद. जय हिंद.
गुड इवनिंग टू यू ऑल. सभी लोगों को मेरा इस शाम को नमस्कार है. रिस्पेक्टेड चीफ गेस्ट डॉक्टर अशोक जानवी प्रसाद जी, academic heads AIMS Gorakhpur, my mayors Gorakhpur और my मेरा senior डॉक्टर मंगलेश कुमार श्रीवास्तव जी, प्रेसिडेंट डॉक्टर जयश्री विमल जी, डॉक्टर SP अग्रवाल साइंटिफिक सेक्रेटरी, डॉक्टर प्रतिभा गुप्ता सेक्रेटरी, स्पीकर्स डॉक्टर विनीश माथुर जी एंड डॉक्टर दीपक गुप्ता, डॉक्टर कन्हैया अग्रवाल स्पीकर्स एंड सभी रिस्पेक्टेड कलीग्स। I feel very honor and very pleasure with you all। आज का जो GP एसोसिएशन गोरखपुर के द्वारा एक CME जो ऑर्गेनाइज्ड है, जो तीनों टॉपिक्स हैं, हाइपोथायरॉयडिज्म एंड इट्स मैनेजमेंट, क्लिनिकल पल्स, ओवरव्यू और रेडियोथेरेपी विद साइबर नाइफ एंड एडवांसेज इन द ट्रीटमेंट स्पाइनल डिसऑर्डर्स। ये तीनों टॉपिक्स ही बहुत ही यूज़फुल हैं हम सभी ब्रांचेस के लिए, सभी स्ट्रीम्स के लिए। आजकल हम लोग पूरे लाइफ में, प्रोफेशनल लाइफ में हम देखते हैं कि केवल क्लिनिकल CMEs पर ही विशेष ध्यान दिया जाता है। जहाँ पर भी हम जाते हैं वहाँ पे क्लिनिकल CMEs होते हैं, उसी पे डिस्कस करते हैं और पूरी केस में इन्वेस्टिगेशंस हैं, डायग्नोस्टिक है, ट्रीटमेंट है। इन्वेस्टिगेशंस में हम लोग होते हैं बायोकेमिस्ट्री ले लेते हैं, हीमेटोलॉजी ले लेते हैं। इमेजिंग में हम लोग CT स्कैन, अल्ट्रासोनोग्राफी, MRI एक्सेट्रा में ले लेते हैं। और क्लिनिकल जब डिस्कशन करते हैं उसके सिम्टम्स और साइंस में उलझे रहते हैं। पूरी हमारी प्रोफेशनल लाइफ एक उलझन में रहती है, उसको समझने में ही पूरी लाइफ गुजर जाती है। लेकिन हम मेन चीज़ जो होता है, जो बेसिक चीज़ें होती हैं, जो हमको आज की ज़रूरत है, जिस पे रिसर्च की ज़रूरत है, R&D की ज़रूरत है, इनोवेशन की ज़रूरत है, शायद ही हम सभी लोग अपने अपने स्ट्रीम्स में जाते हैं, CMEs में, सेमिनार्स में, कॉन्फ्रेंसेस में, शायद ही बहुत कम डिस्कस होता है। R&D पे, रिसर्च पे तो कहीं पे एक आध अगर कहीं पे सेशन होते हैं तो वहाँ पे बैठने वालों की संख्या शायद ही 1-2 होती है। कॉमन टॉपिक्स जो होते हैं, जो ब्रेड बटर होते हैं या जिसमें एडवांसमेंट होता है, उसमें मैक्सिमम नंबर्स होते हैं। हम चाहेंगे जितने भी स्ट्रीम्स के सभी लोग, GP एसोसिएशन ऐसा सभी स्ट्रीम्स के लोग का एक संगम है। सभी लोग अपनी अपनी फील्ड में जितने भी एसोसिएशन हैं सभी स्ट्रीम्स के, उसमें इस दिशा में कुछ R&D की दिशा में, जो बेसिक साइंस की दिशा में भी कुछ आगे बढ़ें, डिस्कस करें, लोकल लेवल पे कुछ करने की हम लोग आपस में इंटरेक्शंस करें। एम्स भी है, VRD भी है, आप लोगों के भी एसोसिएशंस हैं। हम सभी लोग इसमें इस तरफ भी आगे बढ़ें कि कुछ न्यू इनोवेशन की तरफ भी अपना इंटरेस्ट क्रिएट करें। वही हमारा फ्यूचर है। और नहीं तो जो भी ये चीज़ें क्लिनिकल चीज़ें हैं हम उसी में उलझे रहेंगे, और जो भी ओवरव्यू रेडियोथेरेपी विद साइबर नाइफ, ये कभी डेवलप नहीं कर पाएंगे। पूरा का पूरा इम्पोर्टेड ही रहेगा, कभी इंडियनाइज्ड नहीं होगा। हमको इसी शब्दों के साथ और उम्मीद करते हैं कि हम सब मिल के, जितने भी गोरखपुर के सभी स्ट्रीम्स के मेंबर्स हैं, एक जब भी CME करें, कुछ इसके बारे में सोचें और इसके तरफ कुछ आगे बढ़े। थैंक यू वेरी मच फॉर कॉलिंग।
सभी डिग्नेटरीज जो अभी डैश पे थे और चले गए, अभी CMEs के लिए वापस चले गए हैं, हाँ, चेयर्स पे, एवं दर्शक दीर्घा में बैठे सभी सम्मानित मेंबर्स व मित्रों को हार्दिक अभिनंदन। 1 साल पहले इसी होटल में, इसी हॉल में एनुअल साइंटिफिक मीट का आयोजन हुआ था और बहुत अच्छी तरह संपन्न भी हुआ था। मुझे GP एसोसिएशन के सेक्रेटरी के पद पर काम करते हुए 2 साल पूरे हो गए। आज थोड़ी भावुक हूँ मैं कोशिश करती रही कि लोग मीटिंग्स में आए, स्पेशली जो बुधवार को मॉर्निंग में होती थी, और सब लोग इस CME और कोई भी जो आयोजन हो रहा है GP का उससे जुड़े रहें। इस बात से खुश हूँ मैं कि आप सभी का सहयोग व आशीर्वचन दोनों प्राप्त हुए। डॉक्टर मंगलेश श्रीवास्तव सर, जो हमारे शहर के माननीय महापौर हैं अभी, वे भी GP एसोसिएशन की मीटिंग्स में रेगुलरली आते रहे। सर, दिल्ली से धन्यवाद आपका। डॉक्टर राम कुमार जायसवाल सर, जो BRD मेडिकल कॉलेज के प्रिंसिपल हैं, वे भी GP की मीटिंग में एज चीफ गेस्ट शरीक हुए और उनका भी बहुत सहयोग रहा। सर, आपका भी बहुत बहुत धन्यवाद। डॉक्टर अशोक प्रसाद सर, जो डॉक्टर होने के साथ साथ एक विनम्र इंसान भी हैं, उनका मैं तहे दिल से धन्यवाद बोलना चाहती हूँ। सर, शुक्रिया आपका। सर, हमारे पड़ोसी हैं, मेरे घर के पास रहते हैं, मैं खुद को बहुत गौरवान्वित महसूस करती हूँ। सर, हमारे लिए सोर्स ऑफ इंस्पिरेशन है। बहुत बहुत धन्यवाद सर आपका। वक्त तेज़ी से बीत रहा है और अभी बहुत कुछ सुनना और कहना बाकी है। मैं गुड़गांव मेदांता दिल्ली से आए हमारे गेस्ट स्पीकर्स डॉक्टर विनीश माथुर एवं डॉक्टर दीपक गुप्ता जी को तहे दिल से धन्यवाद बोलना चाहती हूँ। डॉक्टर कन्हैया अग्रवाल, जो हमारे शहर के जाने माने इंडोक्राइनोलॉजिस्ट व थायराइड स्पेशलिस्ट हैं, उनका भी स्वागत करती हूँ। वो तहे दिल से उनका धन्यवाद देना चाहती हूँ। वो शायद अभी आए नहीं हैं। लास्ट बट नॉट द लीस्ट, मैं अपनी लिखी हुई कविताओं की चंद पंक्तियाँ आप लोगों के समक्ष प्रस्तुत करती हूँ। सभी शुभचिंतक हैं हमारे, सभी शुभचिंतक हैं हमारे, सभी समर्थक हैं हमारे, विश्वास की धारा में बहिए, मन की बात अपनों से कहिए। ये बहुत छोटी थी इसलिए एक और सुनाऊंगी मैं। कभी इकरार है, कभी इकरार है, कभी इनकार है, मन अपेक्षाओं का बाजार है। इस बाजार में गम ज़्यादा बिकते हैं, खुशियों की उपलब्धता शायद कम रहती है यहाँ। पर अच्छे व सच्चे खरीदार गम को नज़रअंदाज करते हैं, खुशियाँ खरीदने का यथासंभव प्रयास करते हैं। थैंक यू ऑल फॉर कमिंग। और हाँ, अब मैं जो पूरी एक्टिविटीज़ हुई है वो मैंने कुछ स्लाइड के फॉर्म में मैं प्रस्तुत करना चाह रही हूँ। आप लोग देखिए, आई होप एवरीबडी विल अप्रिशिएट। थैंक यू सर। फर्स्ट फोटो इज योर्स, डॉक्टर अशोक जाह्नवी प्रसाद सर। Thanks for your welcome. We went your home. You entertained us. Thank you, sir. Second is we have invited our MP Shri Ravi Kishan Shukla ji for annual cultural event that is going to happen on 16th. We clicked very colorful photograph it is. And now details of our general meet and cultural meet. 10th July we had 10th July we had executive body meeting, newly enrolled. 24th July we had carom board tournament that was organized by our sports secretary Dr. PC Sahi. 27th August again it was badminton tournament. 2nd October it was we participated in Swachh Bharat Abhiyan. Next 10th November we had GBM come Diwali meet. We enjoyed a lot, had dance and songs together. 28th January we had again executive body meeting of GP Association. 4th February we had mega health checkup camp at Gangotri Mahila College. It was a well organized and very successful camp. 1st May we had executive body meeting of GP Association. Now we can see the photographs, very colorful, I think, very colorful it is. We have all photographs of morning CMEs which we do regularly on Wednesday every 15 days. The talk was an update on benign disease of breast, speaker Dr. AP Gupta. Again badminton tournament with Honorable MP Ravi Kishan sir and Mayor of our city Dr. Mangesh Srivastava ji. Pathological fracture, we had talk on pathological fracture, multi-speciality approach, that was on 9th September. Speaker Dr. Imran Akhtar, he is in medical college. We had talk on benefits and challenges of medical practice. That was on 27th September. Again, speaker was Dr. Imran Khan. We participated in Swachh Bharat Abhiyan on 22nd October on occasion of Gandhi Jayanti. We enjoyed a lot doing all jhadu pocha and everything near Taramandal area. We had talk on hypoglycemia management and evaluation. That was on 27th October. Speaker was Dr. Abhijit Gupta, physician. We had GBM cum Diwali meet. That was on 10th November. Then again talk was on cuffless BP monitoring. That was on 6th December 23. Speaker was Dr. Alok Gupta. We had talk on diagnostic bronchoscopy, role in respiratory disease. That was on 27th December. Talk was by Dr. Amir Nadeem. Again talk was by Dr. Vishrut Bharti. He is urologist, neurosurgeon, knowing urethral stricture disease and its current management. That was on 7th January. We had our executive body meeting on 28th January. We had mega health checkup camp at Gangotri Mahila College. That was on 4th February. And thanks to our GP members who participated, Dr. Deepti Chaturvedi, Dr. Bhavita Shukla, Dr. PC Sahi, Dr. AP Gupta. It was very nice camp, and people are really enthusiastic to have their medical checkup, and we should do it regularly. There was media coverage of this mega health गंगोत्री. थैंक्स टू मीडिया पीपल, बहुत ज़्यादा अच्छा कवरेज आया था, सारे पेपर्स में आया था, ऑलमोस्ट एवरी पेपर न्यूज़पेपर कवर्ड दैट न्यूज़. We had talk on diabetic retinopathy. That was speaker was Dr. Kirti Mittal. We had talk on update about cancer, what all doctors should know, and the talk was by Dr. Diksha Chaturvedi, budding radiologist, radiation oncologist. She is here also, I know. Okay. Now we had talk by Medanta, Lucknow people. Speakers were, that was on 12th March. Robotic surgery talk was given by Dr. Puneet Aluwalia. That was on 16th March. Talk was on cardiac surgery, pros and cons. The speaker was Dr. Ritvik Raj Buyan, came from Fortis Hospital. Talk was on Gaurav Narayan Gupta, same day, same evening. That was on, क्या talk था? Talk was by Dr. Gaurav Narayan Gupta, cardiologist of Gorakhpur. We had again executive body meeting on 1st May this year, 1st May 24. Again CME on gynecology oncology. That was on 22nd May. His speaker was Dr. Sahana P. She is gynecology and oncologist. Again there was talk on coronary bypass surgery, 25th May. Speaker was Dr. Pankaj Srivastav from Charak Hospital, Lucknow. Now we had press conference day before yesterday for this CME. It was also, they came to my hospital also, and we had in Gorakhpur Place Club. That was also covered by media people. And we lost this year our 3 senior members of GP Association. Dr. S.N. Gupta sir, he was a renowned radiologist of our place, Gorakhpur. Dr. S.N. Agrawal sir, he was also radiologist. And Dr. Salil Chaldara, he was also radiologist. We miss you very much. And with this, thank you all for patient listening. Thank you.
Actually, good evening everybody. We started this GP association. I know I was just a beginner then. Beginner in the sense, I came from Hyderabad actually. I'm a graduate of Osmania University, and from there I happened to come to Gorakhpur of all the places. I didn't know why, but I'm here till now. Believe me, Gorakhpur has given me a lot of love in other ways. All the people here, all the doctors here, associations, they're very nice to me. And I'm all alone now, though my husband has left me and gone. But even then, this love and affection, probably I'm going to die here only. This is the way I feel. And GP Association has been doing a lot of work, and I've been president of all the associations here. And when we see youngsters passing away in front of us, it pains a lot. It really pains us a lot. And all three radiologists last year we lost. And we want health, good health for all the people. On that basis also we should go on, take another step forward and work for the wellness of people, good health. And many, I don't know, I come to know when I read. Many people don't even know what is their diet that consists of. Protein deficiency, vitamin deficiencies, all deficiencies are there in so many of us, and we don't realize. And we should work on all these levels also, give them good health. That is my proposition. Thank you all.
This honor, a GP has a great role in private practice. GP and patient relationship is quite good. Patients जितना एक GP से मिलके बात करता है और GP उसको जैसा समझता है, टाइम देता है, तो उससे उसको काफ़ी संतोष होता है. I think GP जितने दिन रहे, प्रैक्टिस करे, भगवान उसको ऐसे उम्र. Thank you. Thank you.
Dignitaries, colleagues, senior and junior, it's a pleasure to be in Gorakhpur, and I'm really impressed by the number of people who have taken the time out to come and listen to a slightly esoteric topic on a day when we are actually competing with political events and sports. So a big thank you and a big shout out to all of you. Thank you for coming. I am an orthopedic surgeon by training and have been fascinated and am very passionate about spine surgery right from my undergraduate, my postgraduate days. Fortunately, Medanta Gurugram has given me the platform and the availability of equipment, manpower to carry this out to my satisfaction. So that's me in the OPD looking at the spine. Now the interesting thing is that at one time there was a little bit of a confusion as to where spine actually belongs, whether it belongs to orthopedic surgeries, neurosurgeons, or sometimes even general surgeons. In fact, even today I think when patients come in, that's one of the most common questions, who is going to treat this? My answer to that is that over a period of time, like general surgery has fragmented into so many other branches, both orthopedics and neurosurgery have taken a little slice out and combined to make a joint spine unit, and that is what we do basically. We run a combined spine unit and treat spinal diseases as a separate organ system rather than being part of one of the older specialities. Now, if you look at the spine, there are 24 vertebrae, there are close to 100 joints, 2 curves, major, 2 minor curves, all aligned together. And the fascinating part of this is that no other animal actually uses the spine in the way that human beings do. Most animals walk plantigrade, they are not walking erect, and the spine in human beings is subject to pressures and to forces which are not experienced by any other animal. In fact, if you look at it, in most disorders you have animal models for almost every disease, including cancer, diabetes, everything. But there is hardly any animal model available for a spine disease, because spine disease is primarily an evolving human situation, and which is why it is so common, because our spine is not really evolved. If you look at the million years of evolution of the human race, the spine has still not fully evolved. I'm sure we are going to have better spines in the future, maybe a million years from now. And it is a complex interlocking system with as many vertebrae. The ribs are part of it, and the pelvis and the sacroiliac joints often missed as part of the treatment for the spine. A lot of pathology comes from these areas. Now, the management of spine disorders has been typically the first question that people ask, even doctors. We have a lot of doctors as patients. For some reason, they like to come to our hospital. They say, "Ye kyun hota hai?" and why does it occur? And we just did a little demo here, and I will not keep the talk too technical, because I'm sure a lot of you will be more interested in the semantics around the spine rather than this. So those are little coffee cups. It's very easy to align something when it is lying flat, but the moment you try to do it when the person stands up, the mechanics of the joints of the spine changes completely. So we did this little experiment. We had only coffee cups at that point, but it just emphasizes a point that you can align almost anything when they are in line, but it's very difficult to keep them up when they are erect. And we do the same thing when we line up these cups, and this is exactly what happens. You can do it any way you like when the cups are in line, not putting weight on each other. The moment you try to do this is what happens eventually. And remember, there are 24 of these vertebrae, very complex system, very difficult to also say where the pain generators are coming from in the spine. So we come straight away to the challenges of management of spinal disorder. Diagnosis has been a problem over a period of time. An honest assessment would be that in about 60-70% of cases, we don't really know generators of pain in the spine. That's a huge number. I mean, about 70% of patients, we can't really pinpoint what exactly is causing degenerative pain. You can see a lot of pathology. You can see a lot of people, and you are a fairly old population, if you get a random MRI done on a 60 or a 70-year-old, you can see changes in the spine, and you can have a person who has hardly any problems. And the other way around also, you have a lot of people who appear to have clinical problems. So identifying pain generators is a problem, and though it has been helped over a period of time with technology and with imaging, but it still remains a big problem. As far as actual treatment is concerned, I think these are the questions that mostly come up with most of our patients. The first is the apprehension of disability, and the first thing that people say is that, will the treatment leave me worse off than what I was earlier, or will it make me better? It is surprising that so many people are willing to stay more or less the same, but the apprehension of being worse off, I think, dissuades them from going in for treatment for the spine. Of course, the effectiveness is also a matter of question. Surgical treatment barely covers about 5 to 10% of the random OPD cases that we see. 90% of cases like we see, we do not treat surgically, and whether at all we achieve anything is also a question, and that has been asked very rightly by many patients. And cost, of course, is a big factor. Technology as of today is expensive. We expect costs to come down like everything else, but we don't expect things to get much easier in the short run. So what has changed? When I started off doing spine surgery, it was limited to a few hooks and rods. We used to do discectomies, laminectomies, basically decompressions. Deformity correction used to be a very hit and miss kind of a thing. We used to take lengthy consents from patients because we were not sure, we as surgeons were not sure what kind of outcome we were able to develop. And in fact, a lot of orthopedic surgeons even today do not do a lot of spine surgery simply because they consider the effectiveness to be limited and the possibilities of problems to be much larger. So this is what has actually changed, and this I am talking about the period of 30 years in which I started orthopedic surgery and between today. So the first thing is the rise of a specialist spine surgeon. I think I mentioned that we have an exclusive spine unit. We do only spine surgery. We don't do anything else. As simple as that. We don't do neurosurgery. We don't do brain surgery. We don't do joint replacements. There are some people who try to do these things. All I can say is the age of specialization, and the more you do a thing, the better you get it. The limited, it might feel a little limiting for some surgeons to do only one kind of surgery, but believe me, your skill levels, your treatment effectiveness definitely increases. And nowadays we have very good subspecialty courses also. We have DMBs and FNBs working with us who are actually training only for spine surgery. And this was a popular this thing about orthopedic surgeons. I do hips also, I do knees, I do spines and things. The skill set needed, the mentality needed to do a spine surgery is completely different from one that is needed to do a knee arthroscopy or a sports medicine procedure or a shoulder replacement. Also, the number of patients have increased. If you look at the epidemiology, and I can see quite a few white hair in the audience, disproportionately high, if I may say so, there is economic growth. People are older but mentally younger. They want to be active. There has been a fragmentation of the Indian joint family. A lot of our patients who come in, and now we are operating patients in their 90s. We are doing elective spine surgeries, 90, 95 years old patients. I can definitely tell you, 20 years back, this was unheard of. People above 70 years would not come for getting any kind of elective procedure. Even cataract bhi mana kar dete the us time pe. I'm 75, I won't get it done. Spine surgery is an absolute no-no. We are trying to break those taboos, trying to increase the reliability and convince patients. The fact is that a bad spinal disorder, and all of you, I think 70% of adults over 60 years have had at least one bad episode of back pain. It immobilizes the patient. In the current nuclear kind of family situation, children maybe in Bangalore or USA or somewhere, a lot of doctors send the children abroad. We have fragmented, high geriatric patients, maybe just a husband and wife, or even not, and they need their mobility. They can't be in bed. That support system is completely gone. Unfortunately, no government and no social development has created replacing structures in place. So these people need to be mobile, and most of them now get operated because it's a necessity. They can't survive otherwise. Of course, they are fitter. We have so many patients now who come with, who got bypasses, who got liver disease, chronic kidney disease, diabetes, 1/3 of the population. And over a period of time, we have learned to operate all of them. So this is some of the stuff we do. Diagnostics has also made a change. Our availability of the MRI, I think, and the quality of the MRI, the quality of training of radiologists has improved. We are able to pick up pathology, especially our new generation 3 Tesla machines with high spin rates. You can get really good images. You can see every little nerve root, every little thing. I must say though that over a period of time, the importance of the radiologist has actually increased. When we used to have low resolution machines, we could read the MRI as well as a radiologist. But nowadays, we rely more and more on a radiologist to tell us what exactly is wrong. We have broadband internet. We don't realize how important that is, because sometimes you have a problem, you can concur with colleagues around the world. So I think we'll just jump ahead with that. And of course, our anesthesia ICU care has improved over a period of time. Now, what has changed as far as the surgery itself is concerned? Why are we so confident? Why can we tell a 60, 70-year-old person that I'll do a 1-level decompression fusion and I'll get you out of hospital in 2 days? The first thing is, of course, like I said, a dedicated surgeon. Magnification. The use of magnification is almost ubiquitous now in surgery. Naked eye surgery is almost out. Using microscopes, endoscopes, and loop magnification is almost mandatory. Our intraoperative imaging has improved dramatically. From the low-end CM available to us, we now have good navigation-based systems. We have microscopes, we have endoscopes, like I said, and we have the O-arm, which allows us to visualize the spine in 3 dimensions as we operate with very little radiation. Another major change has been the availability of experienced neuromonitoring. Those are the types of neuromonitoring. I won't go into the details, but the ability to monitor neural function. And if you ask patients कि आपको सबसे बड़ा डर क्या है spine surgery का, is the fear of paralysis. Even surgeons from other specialities also say कि तुम लोग करते क्या? I mean, what do you do? Every third patient is aware and afraid of getting paralyzed during surgery. So the ability to monitor cerebral, posterior tract, anterior tract during the surgical procedure has made us much more confident. There was a time when we used to do scoliosis, we used to inevitably do, and if there are some anesthetists here, something called a wake-up test, which means we used to lighten the anesthesia, make the patient move his hands and feet, and then again put him back and close the wound. And similarly, I remember when I used to operate, I did not used to go home earlier till the patient was awake, turned around, moving his toes, and then go out and counsel the family. Now with effective neuromonitoring, we just walk out after the major part of the procedure is concerned and leave it to our juniors, because we are very confident that we have not caused any further damage to the area. The implants have improved. The metals, the availability of implants, especially after liberalization, we have huge number of implants available. The kind of technology available for manufacture of used implants has also made dramatic changes. These are the pedicle screws. These are the workhorse of our system. This is how we put them in. These are cannulated pedicle screws. We just put our old Jamshedi needle, the kind that you use to get bone marrow aspirations out, put wires and thread everything. I'll show you a few more slides down the line. And there is actually so much innovation in implants that we can actually go around almost every vertebra at every angle. You can go around. It's just to show how do we a simple one level decompression and two level decompression and fusion, and this is through small holes. It's microscopic. There are just 5 or 6 small holes through which we do these procedures. I know this is a little sped up, but I didn't want to waste too much time on the actual videos, and this is what it looks like. Believe me, I will show you some other slides. We monitor all our patients, we share our videos with our patients, we show them videos of other patients, just in an effort to keep on convincing them that something is being done. That's another one. This is a monitoring thing. I think we'll skip that and just go on. We are doing a lot of revision surgery nowadays because of the way spine surgery has been done in the say 90s and 2010s. A lot of patients come up with revision problems. They have degenerative problems next to the levels in which they have been operated, like something like this. This was, I think, a tubercular lesion that was operated somewhere. The implants have worked out. The fixation is completely unsatisfactory. We revised that and done this. This is another interesting area for us. We are doing a lot of degenerative scoliosis. Now, this was considered almost untreatable about 15 years back, but there has been a huge amount of interest in this thing. Minimally invasive treatment for degenerative scoliosis. Again, these are 60, 70, 80-year-old patients, multiple medical problems, poor bone quality, osteoporosis means we rarely operate on anybody in that age group with normal looking bone. So implants is a problem. Over a period of time, we've kind of, this is just one of the examples. I spent a little time on it. Again, about 75 or 80-year-old lady, and she came in with a stenosis and a degenerative scoliosis. Now, some people would typically do just a decompression for this, remove a little bit of disc, remove a little bit of lamina. The problem is that only buys about a couple of years for the patient. And if you ask me, it is really no different from getting an epidural block or something. It works as a pain relief procedure, but not as a curative procedure. This is what we have done. This is completely minimally invasive, small incisions. You first take a look at the spine, put our small cuts, put the Jamshedi needles in, put wires over them, thread screws over them, then we use our endoscopes, remove a little bit of bone, go anteriorly, excise the entire discs. You'll just see it coming up there. So this is just the wiring part of the thing. We put guide wires along the entire length of the spine. This has been an area of interest for me, and we are actually pursuing this very actively. So once our implants are in, and then we so far we just had about 5 or 6 cuts in this process. Then we go in through our endoscopes and correct the deformity. We use these little dilators, open out the disc spaces, put spacers in that place on the side of the concavity of the deformity. We have these lovely expandable discs which can actually open out. You put it into a contracted or a shriveled out disc, open them out, and the only downside to this surgery is it is very boring for the assistant because he has nothing to do. He just waits patiently. Our residents try to run away from spine surgery because they have nothing to do in this, and almost the entire procedure needs to be done. So we've done L5S1 out here. Neuromonitoring continuously. There's so much hardware out there that we have no option. I mean, if I wouldn't ever do this case without proper neuromonitoring. Then we put our contoured rods and gradually distract, compress and reduce the spine and try to get it all into shape. And this is what we end up. We look with almost straight spine, decompressed. The disc spaces have been broadened out. Remember, just doing a decompression out there leaves the bad disc in its place. We actually open out the disc space to normal. This is how it looks like. As one of my residents said, this looks like a Bhishma Pitama surgery. You know, the longer you go, you have people this thing. But this is exactly how, and those are the incisions that we actually get. This is cut out a little, and that is our post-op result. Now, this video has been mixed up a little by my assistant, but this lady is out of her bed next day after surgery. So next question patients ask you, operation के बाद कितने महीने आराम करना पड़ेगा? I said 12 hours. Most of our cases are out of bed in the next 12 hours out there. I'm sorry the video somehow has got reversed in the sense it has rotated, but you can get the image. This patient is out of bed. We didn't even catheterize her, so no UTI, no problems with catheterization. She's out of the hospital in 4 or 5 days. This is in the morning after surgery. We use this for children also with idiopathic scoliosis. We are doing more of them. Some of them have to be done open out here like this. You can get almost 90% correction. This is the last one that we just did. So I just put it in there. So what can we achieve? We can decompress almost any level from any anterior, posterior, lateral, side से कहीं से भी जाके we can achieve decompression from almost all around the spine. Instead of just thinking of us as posterior surgeons, we can go all around the spine and get a full decompression like this one with a cervical spondylotic myelopathy. We did anterior, then we went in posterior. So effectively we have removed the entire bone around the spinal cord and left enough space. We can control and correct a lot of deformities. Very, very bad deformities also can be controlled, fixed, straightened out. Spondylolisthesis, high-grade listhesis, we are able to put back, fix, fuse, decompress. We can achieve bony fusion between the vertebrae, thereby getting alignment back to the spine and giving stability, protecting our implants also. And we are increasingly now relying on disc replacements and facet arthroplasty. This is what we do in the cervical region. This is almost state of art in the sense we do these routinely. Lumbar disc replacements have technical problems, longevity issues, so we are still working and trying to find a way around them. So it is always interesting to see what you can't do. We don't like to play God. A lot of deformities can't be corrected. Congenital deformities can't be corrected because there is a fundamental imbalance between the spinal cord and the bony spine, which cannot be ever overcome, the way you can do it in a degenerative problem. We can resect solitary tumors. We have done a fair amount. The time is short, otherwise I would have shown you a video. We can solitary अगर tumor होता है या solitary metastasis होता है, we can get it out. Obviously multiple we don't do it. What we can't do is restore vascularity to neural structures. The first patient of spine diseases that I saw as a postgraduate was a patient of complete paraplegia. Regrettably, after almost 35 years, we have still nothing more to you can't really offer them cure. You can offer them rehabilitation, treatment, better management of bladder, bowel, etc. But there is nothing that has actually happened, at least in my lifetime so far, which has changed the management of paraplegia or neural tract disruption. So, like I said, all deformities cannot be corrected. Sometimes you have to be wise and step back and accept a limited correction and hope that the patient forgives you. So, spinal cord regeneration is a holy grail. We have been looking at it for, I don't know, as long as I've been in medicine. Nothing so far, stem cells, A cell, O cell, nothing so far has actually been proved to be effective. Robotics are now making their way in. Some people call them a marketing tool, some people call them the future, but they definitely increase the precision and the accuracy of our surgery. Because of the very nature of the product, I think we will see more and more of robotics in the future. At this point of time, except for certain difficult situations, we have a very limited use for them. Now, spine care is collaborative. You can do a wonderful surgery. you have to rely on therapists, patients' relatives to get the kind of treatment that you want. Thank you, everybody.
माइक रोटेट कर दीजिए प्लीज.
Yeah, Dr. Mathur, I'm Dr. Agarwal, orthopedic surgeon. So it's a very wonderful presentation, but I want to ask one thing. In spondylolisthesis, grade 3 and 4, do you reduce by your plates and other things, or you leave as a C2?
Okay. That's a fair question. There have been a lot of studies in this regard also. Whether you should, the question whether you should be trying to reduce spondylolisthesis at all or not. That is the fundamental question. Whether you should be trying to put it back in its position or not. Now, patients do ask this question also. Okay, will this actually come back? Because it's a slipped vertebra. Will you actually get it back? So we can almost assure you that your symptoms will be relieved because the decompression itself relieves the symptoms in the long run. The mechanics of the spine can be done. Wherever it is possible, we do it. Almost 95% of patients we are able to achieve near 100% reduction. Maybe not 100%, but near 100% reduction. See, this is a hangover from the time when it was thought that jitna kam karo utna acha hota hai. The problem with spine surgery is if you do less, 5 years down the line, patient is back with you with the same problem. If you just do a decompression for the spondylolisthesis, the listhesis will continue to slip. 5 years down the line, he'll still be walking with a waddling gait, pushed out buttocks, walking like that, and then he'll start getting radiculopathy again. We are seeing so many patients who've been, like I said, who've been operated, just simple discectomies done 2010, 12, 14, 16. They're all coming in for revisions right now. If possible, technically one should try, and nowadays we have the wherewithal and the competence to put everything back in its place. The only thing that we really cannot do is in spondylolisthesis is to bring it back in its place and restore movement there. You have to fuse the spine there. That is the only thing. There are some people have made an attempt to put an artificial lumbar disc in spondylolisthesis. That doesn't work.
Yeah, I tell you, I worked in Russia. There is center in the Kurgan. Whether they have developed there, I have been learned, and we are doing a lot. We do apply external fixator under local anesthesia.
Yes, sir.
And gradually, we try to reduce the dislocation. Whatever grade 3, I will show you some cases. Grade 3 and grade 2, we try to reduce the displacement. And we try to have a 2 to 3 weeks anatomical reduction. After that, we do posterolateral fusion. And we do not do any laminectomy, other things. So these technique was developed by the Russians. There was Ilizarov was the doctor in Kurgan. He has developed that technique. So I have been learned there. I think what I am doing also. This technique.
I have done a lot of Ilizarov when I was practicing general orthopedics. We used a lot of Ilizarov, and if you are the third Dr. Agarwal whom I assume, I know you also have done a lot of work in Ilizarov and external.
But Ilizarov in spine.
But Ilizarov in spine, over a period of time, Ilizarov has become. There was a time when he visited Delhi at that point of time. I forgot the name of the gentleman. Throughout Delhi came there. It was so popular. It used to be used for everything: CDH, dysplastic hips, bad knees, non-unions, even vascular disease. Ilizarov procedure used to be done. Over a period of time, this is my perception, is that it has become a niche surgery. For certain things, it is the only treatment. For a gap non-union in the tibia, there is no other real treatment, though there are some attempts at vascularized tissue transfer, but it is still the most effective treatment. At the same time, compliance is a very, very big problem. In private hospitals, I think you have your own centers, if I remember what. In private hospitals, it's a very big problem. You break a wire, you have to take the patient in the OT, take it down. And remember, sir, and this is where I would like to, though this is not really connected to the spine, is that most of the patients who actually come in for limb treatment with the Lizeros have almost exhausted their resources by that time. Probably if it was used as a primary method of treatment, it would be much more effective. But we see patients who have exhausted their financial, physical resources, and then they come for a Lizero. Now, as far as the spine is concerned, perfectly okay. That's exactly what we do. We put particular screws, but if you can do it in the table, close the wound, I think that's a much less cruel way of treating the problem. We don't have any infrastructural issues right now with us. Maybe if there are infrastructural issues, we could think about it.
Thank you very much.
So I would like to ask you, sir, do you get patients of central canal stenosis and what do you do for them, sir?
Well, the primary treatment for central canal stenosis with claudication is decompression. No two issues about that. Now, decompression is of two types. You can do a neurosurgeon's decompression, a classical decompression, which means remove the lamina, remove a little bit of the facet, remove the osteophytes, expose the cord. Or you can do it the way I do it, and that is we do an indirect decompression. In any case of stenosis, most of the time it's the disc space that has collapsed. Basically it is there. So when you are actually doing a decompression in the traditional way, you go in and do a lamellectomy, what you are doing is just relieving the pressure on the nerve root. What I do is, because we are more comfortable as orthopedicians dealing with bones and screws and implants, is we distract the disc space. We have seen that in one of the patients that I showed. Minimally invasively, we go in, remove, do a almost subtotal discectomy, just leave the annulus, put an expandable cage and open it out. Now that restores the anatomy to normal. You will be surprised. You will be surprised, sir, how many cases we open out and suddenly find there is no need to remove the ligamentum flavum in surgery, because the so-called thickening of the ligamentum flavum, it is buckled because the length of the ligamentum is the same and your disc has collapsed. The moment you stretch it out, the bony canal returns to its normal dimensions. So we do, most of the case we do indirect decompression. If a patient has very severe radicular symptoms, one-sided, then for the short term, after all, we are also, perception is important in medicine. पहले महीने में ठीक हो जाए पेशेंट तो ज़्यादा अच्छा रहता है. You can't ask everybody to wait for 3 months. We like that patients. It makes patients happy. We feel happy if they say हाँ पेन चला गया next day after surgery. So we do direct decompressions also. Patient has very severe radicular symptoms. But for pure claudication and very little of ligamentum, sometimes we have ossified ligament, we remove it. We always prefer indirect dissection, but actually returns the spinal canal dimensions to normal.
Complete reversal of function and symptoms, sir. Do you achieve that? That's the basic question.
Well, patients ask that question. I always tell them कि आप दांत बनवाते हो तो उससे फिर अखरोट तो नहीं तोड़ते ना. Let's be humble. Let's be humble. Let's be humble. We cannot restore you back to 20 years. That is the first line I tell my patients. I can restore you to back when you are walking for 3-4 kilometers, looking after your own function, and you did not need a doctor in place. I cannot make you 20 years. Sorry. If I had that treatment, I'd do it first on myself.
सर मैं डॉक्टर नहीं हूँ, एक पेशेंट के हैसियत से प्रश्न पूछ रही हूँ. 2007 में मेरे T4-5 का ऑपरेशन हुआ था. तो मान लीजिए अभी कोई प्रॉब्लम होती है, अभी तो फिलहाल मैं ठीक हूँ, लेकिन अगर कोई प्रॉब्लम होती है तो क्या मैं MRI करवा सकती हूँ?
अगर कोई किस ईयर में हुआ था आपकी सर्जरी?
2007 T4-5 पे प्रॉब्लम.
देखिए मैं जब से स्पाइन सर्जरी कर रहा, एक तो अगर इम्प्लांट नहीं डला है तब तो ये सवाल पूछने की बात ही नहीं है, क्योंकि अगर सिर्फ इम्प्लांट अगर डला होता है तब ये सवाल उठता है कि भाई MRI कंपैटिबल है या नहीं.
वो कंप्यूटर चिप बोल रहे थे कि उन्होंने गैप था, कंप्यूटर चिप लगाया हुआ.
हम डॉक्टर्स बहुत भाषा इस्तेमाल करते हैं मरीज को सिखाने के लिए. आधा टाइम हम वही उसी आर्ग्यूमेंट में निकल जाता है. 90% of our doctor patient consultations is trying to remove whatever misconceptions they have developed from talking to one person or another person. But if there is an implant inside, if there is a metallic implant inside, then there is a question कि MRI कराना चाहिए या नहीं कराना चाहिए. 2000
ओपन सर्जरी हुई थी सर. 2007 में पीजीआई में।
क्वेश्चन इज मेटल है कि नहीं अंदर। 2002 के बाद से मैंने कोई इम्प्लांट ऐसा नहीं डाला है जो स्टील का हो। स्टील की प्रॉब्लम होती है, हम लोग आजकल टाइटेनियम के इम्प्लांट यूज़ करते हैं जो परफेक्टली कंपैटिबल होते हैं एमआरआई के साथ, इसलिए 99% केसेस में कोई प्रॉब्लम नहीं होती है।
ओके, थैंक यू सर।
Basically, I am not a orthopedician, I am a gynecologist. But I am having a common question. What is slip disc and what is the treatment? Is it surgical or any exercise or what?
Okay. Now, this is actually there is nothing like a slip disc. The whole concept of a slip disc came when people used to think the disc is like a mechanical ball which slips out of its place. It's not. The correct term medically is degenerative disc disease. It's a process of degeneration. It's not very different from how you get bad knees. You lose cartilage, आपकी joint irregular हो जाती है, वहाँ पे आसपास bone बन जाती है, soft tissue hypertrophy होती है. The same things happen. So slip disc आप जिस सेंस में कह रहे हैं वो मोस्ट प्रोबेबली जो हर्निएटेड न्यूक्लियस परपोसेस होता है, आई थिंक आई वुड यूज दैट टर्म ओनली फॉर अ यंग 25-year-old पर्सन हु you see this guy is going to the gym, 150 किलो उठा लिया, 200 किलो उठा लिया, and suddenly he has a massive disc collapse. That probably matches what you think as a slip disc. But a 50-year-old person who's been having degenerative disc disease, bad facets, bad जिसकी chronic disease है, उसको slip disc में आता ही नहीं है, because that is, I was just telling the gentleman earlier, that is degeneration of the intervertebral joint basically. जैसे आपके घुटने घिस जाते हैं और वो पास में आ जाते हैं, ऐसे वो जिसके the vertebrae come together. The effect unfortunately is neurological, but the disease is basically a worn out intervertebral joint. So slip disc is a very small, in your sense, is a very small fragment of the number of patients who come with back pain.
Sir, one question. Sir, usually the cases of disc prolapse or slip disc, if it is very not treated by, not relieved by anything, they are being operated. Okay.
Hello.
But do you know about something about the ozone therapy?
जहाँ पे एक वैक्यूम होता है नॉलेज में और ट्रीटमेंट में, वहाँ पे ऑल काइंड्स ऑफ ट्रीटमेंट्स कमिंग इन इट्स प्लेस। लोग, मैं पेशेंट्स को ये कहता हूँ, लोग अस्थमा का ट्रीटमेंट लाइव मछली खा के करवाते हैं, गाड़ देते हैं ज़मीन के अंदर, उसमें thought there is no scientific basis to support anything like ozone therapy. I'm sorry. I know it's an emotional topic because a lot of people claim they've been cured by it. The fact is that as doctors we have to rely on double-blind controlled trials. There's absolutely no evidence that ozone therapy helps. There's absolutely no difference in epidural also. I tell patients it's a pain management tool. It's like giving you anesthesia for your cesarean section, isn't it? It will relieve you for some hours, some days, some weeks, some months. It does not alter the disease. Now, there is one side effect, and that is it is being practiced by a lot of dubious people. I have seen a lot of cases of discitis, infective discitis, because they have not maintained hygiene standards. So discitis hota hai, it has to be done a little carefully. Whether it causes any damage, no. But then I say why? Why? A good epidural shot given by an anesthetist in a reasonably clean place will have more or less the same effect.
But sir, there are 20 years literature. Lot of people in the West, Germany, they were doing the ozone therapy. They say when you put the ozone, first you put the dye, so that you can. We are also doing. So when I detect the dye, and then you inject the ozone, so it's saying the disc.
Sir, इसकी कोई बायोलॉजी नहीं है और कोई वो नहीं है, so I would not like to comment. Like I said, it is like alternate therapy. I generally don't comment on these things because there is simply no scientific reason why it should work that way.
Especially for non-radiation oncologist, what is radiation I can say that there are two important modalities for any cancer treatment nowadays. Either it is surgery or radiation which can cure the disease. Chemo can work with synergism either with surgery or radiation to help the patient to prolong the survival. But the cornerstone of any cancer treatment is radiation as well as the surgery. Radiosurgery, what you can say, is one of the most advanced form of radiation treatment, and it is the most advanced, most precise, and this is you can understand the most recent treatment for the radiosurgery. And over a period of time, for the last 10 to 15 years, the indications has been expanding, and there are a lot of indication has emerged for the treatment of cancer. This radiation is not only used for the malignant condition, but it is also used for the benign tumors, and we'll discuss this over the next 30 to 40 minutes. So what is radiosurgery? What is stereotaxy? There are multiple names given to radiosurgery. It can be, you can listen radiosurgery, you can listen as stereotactic radiosurgery, it is SBRT, it is SABR, like ablative radiotherapy. So there are different terms which have been used over a period of time. So stereotaxy is per se is you can localize the target in 3 dimension, and once you localize the target in 3 dimension from the beams which are high energy beams and focus to the your tumors, whether it is malignant or benign, it is called stereotactic radiosurgery. When it is given in a single session, then it is called radiosurgery. But once you fractionate in 3 or 5 sessions, then it becomes like stereotactic body radiotherapy or fractionated stereotactic radiosurgery. So this is the slide which show you how the radiation has evolved over a period of time. If you can see the image on the left side, for the last in the last 20-30 years back, we used to use the cobalt machine in which we can fire the beam from the 2 to 3 sides, and whatever the normal tissue comes into the path of beam get the same amount of radiation. So we are able to give us some amount of dose which help to control the disease, but that is able to control, but there is a normal tissue that also gets the dose. So there is high chances of toxicity. So radiation can give you a control along with the toxicity. But as we evolve over a period of time, so we learn how to confirm the dose. We have developed some block, then MLC comes into the play, then radiation has become more conformal. And when we started optimize using computer-based planning, then it become IMRT. So we are started to confirm more doses to the target while we are able to spare the surrounding structure. You can see in the image which is there on the third in number. And this is this enough? But there is some motion which is because of the rectal fling, because of the respiratory motion, because of the physiological motion. So we need certain kind of guidance. So what we have planned, whether we are delivering it correctly or not, then it becomes image guided radiation therapy. So what is radiosurgery? So we have evolved from conventional 2D to 3D, then slowly IMRT, IGRT. Radiosurgery is one step ahead what is called IMRT, IGRT, which you have listened in the course of radiation therapy treatment if somebody has received. So what is radiosurgery? Radiosurgery is actually what are the basic key features of radiosurgery? In this, what we do, if you see any conventional treatment in which we give low dose radiation, probably 2 gray, 1.8 to 2 gray, 5 days a week, over a period of 6 to 8 weeks. But in radiosurgery, we condense that 6 weeks or 8 weeks of treatment in 3 to 5 sessions. So we give very high dose of radiation. Another important feature, if you are giving such a high dose of radiation, means that you are focusing on the tumor, you need to deliver it accurately. You cannot deliver that to the normal tissue. So this is the key features of radiosurgery. High dose of radiation, deliver accurately, and it is delivered not in 6 to 8 weeks, it is delivered only a short period of time, which is only 3 to 5 sessions of radiation. And because we are delivering so precisely, the chances of having normal tissue complication is almost less than 1%, or it is close to 0%. So if you talk in radiosurgery, there are linacs which can deliver a radiosurgery treatment. They are equipped to do a treatment, but there are 2 dedicated machines which are actually used for a radiosurgery treatment. One is gamma knife and another is cyber knife. So in gamma knife is a machine in which you can deliver the treatment but only in one session, and also only brain can be treated. But cyber knife is kind of robust machine in which you can treat either of the brain all the rest of the body tumor can be taken care of by this machine. And this machine is specially made for the treatment which is called SRS, SBRT or radiosurgery kind of treatment. So why this cyber knife is so precise, so accurate, and why this is being used for different kind of treatment? If you can see, this is a intelligent kind of robot. In this we do a planning scan, we generate images which is called DRR, which is on the left side, a DRR image. And what robot do, there are camera inside, they real time track the tumor, whatever the movement is there, take the image, match the image in the real time and correct it, so and then treat the tumor. So the accuracy of cyber knife which has been there is close to 0.06 millimeter, means it is less than a millimeter. The machine is so accurate. So moving on to the indications, there are multiple indications which I like to discuss few of the indications in the subsequent slide, little bit in more details. But the indication range from brain, benign tumor, head neck, recurrent tumors, lung tumor, primary, oligometastatic, abdomen, pancreas, liver, prostate, and so on and so forth. So the benefits of radiosurgery, to summarize, the benefit of this radiosurgery is, in gamma knife you can do single, but in this, if the tumor is close to the critical structure, you cannot treat with a single fraction radiosurgery. So you need to little bit more fractionate, which is possible with a cyber knife. And the accuracy which we have discussed is close to 0.06 millimeter. You can treat any part of the body, and the more importantly, like a radiosurgery, you do not need any incision, any anesthesia, no blood loss, no complication like of surgery. So moving on to the indication. First we'll like to discuss the brain. In brain, all the tumors can be, which are operated or in which there is residual disease or in which surgery cannot be done, the radiosurgery is the treatment of choice. The indication range from meningiomas, pituitary, AVM, neuralgias, metastatic, acoustic. There are certain other indications like skull-based tumor, spinal metastasis, and hemangiomas. So moving on to the few of the indications like functional radiosurgery like trigeminal neuralgia, glossopharyngeal neuralgia. We have treated so many patients. In trigeminal neuralgia, the basic cause, most common cause, is there is an abnormal vessel which causes constant rubbing of the nerve, which causes severe pain. The initial and it is a constant pain, and it's result in poor quality of life. Patient having the pain is not controlled with medication, and it remains a poor quality of life. Till date, the first treatment of choice in this is medicine, but the patient subsequently over a period of time become refractory. Then the treatment will be either you do a microvascular decompression, in which you place a Teflon between the vessel as well as the nerve, and another important treatment is radiosurgery, in which you can ablate the nerve. Rest of the function is preserved, but the pain function is controlled with the radiation. So what are the indications for this functional radiosurgery? It is most common is medically, if the patient is medically inoperable, MVD cannot be done. Old age patient, if the patient does not want any invasive treatment, or patient is surgically and medically refractory, and mind you, it gives you an excellent pain control. So if you see, this is quite a magnified image. If you will see that this is the target, which is cisternal length has to be treated as 6 millimeter, and you can see that this does not appear from the image. It is 6 millimeter because it is magnified image. And you delete this and you give radiation such precisely, and the dose fall off is such sharp fall off that the chances of heavy complication is close to less than 1%. If you in trigeminal neuralgia, you are supposed to give a very high dose radiation, which is in the range of 70 to 90 gray in a single fraction. So if you see from the curve, if you are giving 90 gray and at 1.2 millimeter, there is a dose fall of 50%. So almost 3 millimeter you have a dose which is close to 7 to 8 gray. So it is so precise that beyond 3 millimeter you will not have a dose which is going to cause a toxicity. So if you can see in the CT scan, this is a small target and this is the dose which we get. Beyond this, there is a minimum possible of dose or almost a zero dose. The chances of complication are less. And the dose is 70 to 90 gray, which we have discussed. So if you compare the dose in a conventional, if a brain tumor, if a glioma which has been operated and radiation was given 60 gray over a 6 weeks of treatment. But in trigeminal neuralgia, we have to give a dose which is close to 90 gray in a single fraction. So it is almost 28 times higher, and that too in a single fraction. So we need precision to give such kind of treatment, which is possible with a cyber knife or a gamma knife. And overall the control rate, as you compare with the surgery, the pain control rate is almost the same. It is non-significant difference. And the pain, most of the patients respond between 24 to 48 hours, but 90% of the patients do respond within 30 months, and then it becomes a plateau over a period of time and patient remain pain-free. And how it is little bit better with a gamma knife? In gamma knife there are sector cones which you deliver the treatment. You cannot modify that cones dose distribution. But with cyber knife, with a optimized computer-based planning, you can take away the dose. This is a brain stem in which the maximum dose could be 12 gray, but in gamma knife it is close to 24 gray, which is possible. And this is one of the interesting case which we have treated. This is a brain stem cavernoma. The lesion is located, if you can see on the image, in the brain stem. And you can see the patient is having continuously tremor. Patient cannot lie down, but cannot spend even 10 minutes without these tremors. And the surgery cannot be possible in this patient. So we have treated this patient with cyber knife single dose 16 gray, and you can see the control of tremors. The patient can walk, patient can elevate the hand, and there is completely tremors are controlled. And this is how the imaging response look in the lower side. The enhancing lesion is in the pre-treatment, and post-treatment there is a complete necrosis and healing of the cavernoma. Another important indication is acoustic schwannoma. Now you can talk to even neurosurgeon. Most of the neurosurgeon don't, if they have the facility of radiosurgery, then they don't even want to operate acoustic schwannoma because the risk of complication, hearing loss, facial paralysis, and so on and so forth. And this is the ice cream cone appearance, and it is located in the CP angle, whether right or left. And the symptom being like facial, hearing loss, tinnitus. And if you see the most of the guidelines, even if until and unless it is News grade 4, which is compressing the brainstem, you need to decompress. You need decompression because of the pressure symptom. Then most of the schwannoma, the standard treatment is radiosurgery. Whether it is single fraction or 3 fraction, this is the treatment. You don't even need surgery in this group of patients. This is a pre-treatment image of our patient, and post-treatment you see the necrosis, the black shadow which is coming up means the necrosis. The tumor might take its own time, maybe a 1 to 1.5 to 2 years to start regressing, but the necrosis is started as early as 3 months post-radiation. And the control rate is almost 95%, more than 95% with cyber knife, and good hearing preservation rate, good facial preservation rate. It is much better than the surgical series. Pituitary adenoma, we know there are functional, non-functional, there are different doses, microadenoma, macroadenoma. The standard treatment for pituitary is surgery, but the radiosurgery roles comes into play. If there is a residual disease or there is a recurrent disease, then radiosurgery is the treatment of choice in pituitary, and radiation does help in controlling the disease. There is significant improvement. The indication of primary SRS for pituitary, especially if there is medically inoperable because of the comorbidities, if it is surgically difficult, cannot be removed, or patient refused for surgery. This is one of our patients in which we have treated. You can see the pituitary on the right supracella region, and we treated with a cyber knife and see the enhancement pattern has gone down even post radiation 3 months also. Another important indication, AVM. The standard indication, if it is located in a non-eloquent area, either surgery or ambulation is done, but if it is an eloquent area where the surgeon cannot reach, the standard treatment is radiosurgery single fraction. And if you can see the indication range from, if it is peripherally located, residual AVM, and if it is eloquent area where surgery is not done, then the radiosurgery is the treatment of choice. And why radiosurgery is good in AVM? Because there is a tissue which is there in the nidus. You focus your dose there also, and you spare the surrounding area. But AVM per se, it is not that you give radiosurgery, it will obliterate in a day or two. It will take its own time, probably 2 to 3 years. The vessel get obliterated over a period of time. So you need to wait during that point of time to have the complete response rate. And this is what the doses we normally used, and more than 36 months, more than 75% obliteration rate has been reported. So meningiomas are also, the indication of meningiomas remain grade 1, grade 2. If it is operated, residual or recurrent, the radiosurgery is the treatment of choice. For meningioma, this is few of our patients which we have treated. Large meningioma cannot be operated, we have given radiosurgery. This is another patient of left side parameningeal, and we have treated. So the another indication for the radiosurgery is brain metastasis. Nowadays, because a lot of medication has been come, the survival of the lung cancer has drastically improved, which is close to 6 months to 9 months to 1 year. Now the patient with brain metastasis are now living for 4 years, 5 years because of the betterment of drug. And the standard treatment previous era was to give a whole brain RT into this group of patients. But once you give a whole brain radiation, there is a decrease in cognition. There are side effects if you treat the whole brain. But if you treat the focal lesion, whatever the lesion you are seeing, a limited number of metastases, probably close to 5, they can be better taken care of SRS. And the data shows if you nowadays, if you treat with radiosurgery, 1 to 5 sessions of radiosurgery versus you treat the whole brain radiation, the overall survival in both the group of patient does not matter. Suppose the patient do develop metastasis in certain other part of brain, that can be taken care of by radiosurgery in the later part. But the important point is patient do preserve their cognition, memory and everything can be preserved. It means the better quality of life for the patient is there. So this is another patient of the brain metastasis which we have treated, and you can see the beautiful response after brain radiosurgery. This is one more patient for brain metastasis. So moving beyond the brain, what is the role of SRS-SBRT? In head neck cancer, the standard treatment is either surgery or chemo radiation, which take care of the disease. But what happens once the patient develops recurrences, which is a common scenario in head neck cancer after surgeries, after all the treatment is exhausted. And once the recurrence is happened, the standard treatment, if possible, patient should undergo surgery. But what if the surgery is not possible? So this is one of our patient, a later border time treated, developed recurrence in the retropharyngeal node. The surgery is not possible. So we have treated with cyanide 30 grain 5 fraction, and patient remained well for 2.5 to 3 years post SRS. This is another patient of base of time, which initially it was supraglottic larynx treated on cobalt 1998, 2012. He developed second primary, which we have treated with a conventional treatment followed by a cyanide boost, and patient do well for the next 4 years after the treatment. This is one of the interesting cases. This is a case of which we have published also. This is a case of urinary bladder, which developed oligometastasis, single node metastasis, no metastasis elsewhere in the body. And this is because the comorbidity was not operable as per the surgeon. So there is no other option. Otherwise, it is a palliative patient. So we have treated with a cyanide 30 grain 5 fraction, and the patient was controlled for next 3 years with such kind of treatment. This is our initial experience, which we have published for the SRS-SBRT in recurrent head and neck cancer. Later we have treated almost more than 50 patients. We have treated and excellent control rate and the survival in this group of patients. Now moving on to the lung. Now lung has become the most common indication for SRS-SBRT. There are multiple things, you can say operable, inoperable, large tumor. How you can treat this patient with SRS-SBRT? So if you want, the first important indication is empirical SBRT. Suppose this patient has bad lung and patient has solitary pulmonary nodule. There are criteria which has been defined if the patient biopsy is not possible because of bad lung condition. So there is criteria which is defined. If the patient fits in the criteria, and if it is more than 80%, the patient can be treated with empirical SBRT. So this patient, we have treated this patient, biopsy is not possible because the radiological feature, tumor board discussion, patient is not fit for chemo, we have given SBRT. So this is a tumor which we have treated, and post surgery 4 months you can see the complete disappearance of tumor. And this is almost 2.5 years of follow-up. There is no evidence of disease in this patient. Otherwise this patient has become palliative, no treatment is possible in these patients. Another indication is early stage inoperable. The patient who are not suitable for surgery, although they are stage 1 and stage 2, but they are not suitable for surgery because of medical comorbidities, so on. But in such group of patients, if you give a conventional treatment, means 6 weeks of treatment, the chances of control rate are low, and the patient, majority of the patient, almost 34% of the patient do fail where the initial disease was. So the role of radiation was established by the professor of Indiana University, Robert Timmerman. And they have shown that if you treat this patient with SBRT, 3 sessions, 54 gray, you achieve a local control rate of more than 90% in this group of patients. And subsequently more data has emerged, and now SBRT is a standard treatment for medically inoperable stage 1-2 lung cancer. And this has become part of most of the international guidelines. Another important is if the tumor is close to located close to the mediastinal structure. And what Timmerman has learned from the data, if it is located close, then 3 fraction SBRT is not the option because of high risk of toxicity. So what is learned over a period of time, this is led to the emergence that you don't touch this, there is no fly zone, means you do not do SBRT. But slowly we understand, instead of 3 fraction, give 7 to 8 sessions of SBRT, fractionate more, decrease from dose per fraction 15 to 20 gray to 8 to 10 gray. Then this no fly zone become a careful fly zone. This is one of our tumor which is located ultracentral tumor. We have treated 60 gray and 10 fraction. You can see the response rate, that complete disappearance of tumor without having a toxicity. Fourth indication is operable lung, early stage operable lung cancer. Randomized trial has been started with surgery, but because of the poor accrual, the trial was not concluded. But when the data of the multiple trials, 2 trials, important trial was combined, the control rate with SBRT is equivalent what has been shown with the surgery. So this is one of our patients, stage 1 lung cancer, and in the blue slide there is another patient which is located in the lower lobe, stage 1 lung cancer, which we have treated with SBRT. If you can see post SBRT, there is a complete disappearance, post radiation changes, but it slowly resolves over a period of time. This is another patient in which stage 1 lung cancer, proven adenocarcinoma, treated with SBRT. You can see the evolution of response over a period of treatment time, and this is 3 years post SBRT. There is no evidence of disease. So whether it is 1 fraction, 8 fraction, 10 fraction, depend. The next question is whether the same treatment can be delivered in a single session, like a surgeon go and remove the tumor, can we ablate the tumor? So there is a concept of single dose RT, but this has to be delivered in a very selected few group of patients. We have delivered the patient located away from the center, little bit in the mid pole, single lesion, 34 gray, single fraction. This is how we deliver, and this patient was also controlled with the disease. Now what happened to the tumor which are large, which are standard treatment is chemo radiation, but they are not fit for chemo radiation. If this patient is not fit for chemo radiation, the treatment will be chemotherapy, and this patient is palliative. And we discussed with the patient, and we treated with this patient with the SBRT. It is almost 5 to 5.5 centimeter of tumor. You can see the response post SBRT, 3 months the complete disappearance of tumor, and patient was subsequently started on immunotherapy and doing well. 2.5 years post radiation. What if the tumor has chest wall invasion? Initially people think that if you do a high dose tumor there is a chest wall fracture, but we have learned over a period of time how to spare the chest wall and how to give a high dose of radiation. This is one chest wall tumor which we have treated, means the T3 disease, and because this is 80-year-old, COPD, ejection fraction is less, and we treated this same patient with the SBRT, and you can, if you can see the images, there is complete control. With a more image guidance, we are able to give a higher dose. So with the image guidance, we are able to give a dose which are able to cure the disease, which is close to 8 to 9 weeks of treatment. But with the advancement of technique, IGRT, we are able to reduce a course which is 9 weeks of treatment, we are able to reduce by 6 or 6.5 weeks of treatment. We are able to little bit escalate. But still, the treatment time is close to 6 weeks. Can we still reduce? And this is possible with SRS SBRT. What we are able to achieve is, we are able to achieve a very high dose inside the prostate, giving 5 days, 5 sessions of radiation. We are able to spare, if you can see, the urethra also with our planning. And with this, we are able to give an excellent control. If you see the control rate, almost 10 years control rate in low intermediate scale, 94%, intermediate it is close to 90%, and the recurrence rate is close to 3 to 4%, which is there in the surgery also. So urologists remove the prostate, but we do not remove the prostate. We cure the prostate within 5 sessions of radiation. We don't need any surgery in this. So we avoid the complication of surgery like urinary incontinence, so on and so forth. So this is the transformation of the prostate. This is our data. So kidney cancer, which are considered radio resistant, when we give the fractionated rate, there is no role of radiation. But once we start giving high dose of radiation, the kidney tumor, which are considered radio resistant, now they are melting like a ice with the radiation. and the control rate has been reported. There is fast track data which is recently been published. The control rate is close to 95%, and patient don't need surgery even in the kidney patients. And this is our few of our patients which we have treated with kidney cancer. This is kidney mass with a nodal area treated both, and you can see the image, complete control of the disease. Another tumor, other kidney cancer. This is liver. Normally, the hepatocellular carcinoma, the treatment is surgery. But once the tumor goes inside the vein, means the portal vein, it is a contraindication for the surgery. Patient cannot undergo a transplant. So what SBRT can do? SBRT treated this portal vein. We treat this portal vein with SBRT, and there is an opening of vein. So the patient who are contraindicated for surgery can be taken off for transplant. And we have treated around 142 patients, and out of that 53 underwent transplant. The patients who are palliative now become curative with the use of SBRT. And this is liver metastasis. Liver metastasis is one of the indications. Not go into the detail. And pancreas, the borderline unresectable, inoperable, pain, SBRT has this role. So there are many other indications I can discuss, so on. But these are the common indication. But the last message is it is not only the machine which do it. It is the man behind the machine. What we do it, what dose we do it, how we do it, how we spare the critical structure, that matters a lot. So with this, I like to thank you. This is my team, and thank you very much for inviting me.
Thank you, sir. Thank you for your very elaborate presentation of the talk. I think we are... Okay, Dr. CM Sarasa, please.
Well, Dr. Gupta, your talk has been extremely fine, and it was an eye-opener for us because you told us that all those inaccessible tumors where surgery cannot be done, and for many tumors, whether benign or malignant, right from head and neck to right from the brain, head and neck, lungs, breast and pelvis, we can get the patient treated by cyberknife, and it is quite an eye-opener for us. And we'll have the question ask session after all the sessions are over. But one thing I would like to say, because मैंने ये देखा कि जब GP एसोसिएशन का ये सेशन स्टार्ट हुआ तो ये बिल्कुल कविता में और शायराना था. हमारे जो स्पोर्ट्स सेक्रेटरी थे, हमारे सेक्रेटरी थे, फिर हमारी साइंटिफिक सेक्रेटरी थी जो डॉक्टर प्रतिभा गुप्ता, सबने कुछ न कुछ शायरी और वो सब कहा. तो डॉक्टर गुप्ता के बारे में मैं 2 लाइनें कहना चाहूँगा कि जिस तरह एक फूल की खुशबू का कोई रंग नहीं होता, वो महज एक खुशबू होती है. जिस तरह एक बच्चे की मुस्कुराहट का कोई मजहब या भेदभाव नहीं होता, जिस तरह उभरती हुई सूरज की किरणों का या मासूम हवाओं का कोई खैर गांव, देश या वतन नहीं होता, उसी तरह डॉक्टर गुप्ता की शख्सियत कुदरत की तकनीक का एक करिश्मा है. और मैं चाहता हूं कि ये करिश्मा लगातार बढ़ता है. और आप लोगों से मैं गुजारिश करूंगा कि इनका इतना जोरों से तालियों से स्वागत करिए कि हॉल जो है तालियों से गूंज उठे. थैंक यू सो मच.
Thank you very much.
Thank
if you. Have any question you can discuss, I am there.
Thank you, sir. Thank you so much, sir. So I'll like to request Dr. Ram Kumar Jaiswal, sir, to please felicitate this speaker with memento and certificate.
Of common interest. So now I will invite Dr. Kanhaiya Agarwal to kindly give his deliberation.
Thank you, sir, for the introduction. So first of all, I would like to thank you, the GP Association, for inviting me to talk today about the hypothyroidism. So for all the young doctors sitting over here, I would like to thank you to give me an opportunity. So first of all, I also thank you all the respected seniors over here. They're sitting so long in the night. I will not take much time. Before wasting much time, we all know about the treatment of the hypothyroidism. But when we miss the hypothyroidism, it is very much important. So I will discuss with the case. So these are the disclaimer. I have taken few cases from my ex-executive Bhantali sir, Badara sir, department, and also thank you the GKP doctors to send me the cases so that I could have presenting over here. So first case is the 14-year female who presented to me with a severe short stature with delayed puberty. She had normal birth event, her malnutrition was delayed, and she was resident of Kushinagar. Her height was 102 cm with -7 HDS. Weight was -23 kg with -3.3 HDS. She has coarse facial structure, crocky eyes, and delayed tender reflex. No goiter, no lingothyroid, and her pivotal stage was B3 with P1 and no axillary hair. She was the OPD picture of my client from clinic, and she had a height of almost 100 centimeter. So what we found that she has the TSH of 750, and this one TP was negative, prolactin was 8, cortisol was 8 microgram per dl, no thyroid tissue were seen, and she has congenital hypothyroidism because of absence of the gland in the ultrasonography. She was started with the levothyroxine and she was given 25 microgram per day. She was built up to the 75 microgram per day, and also she was replaced later on for the hydrocortisone, because in the initial what we see that when we supplement the patient with the levothyroxine, there is an increase in the requirement for the cortisol level for the maintaining the BMR and other hormone status like T3 is upregulating the receptors. So that we need to give the short-term steroid therapy for like 1 to 2 weeks. And she became active. Her height gain was 10 centimeter in year, and she also had the spontaneous progression in the secondary sexual characteristics. So she had the congenital hypothyroidism, which is very much common. So what is the very important thing is that neonatal thyroid screening should be followed in each and every pediatrician OPD, so that we can suspect and we can detect the congenital hypothyroidism. Second case of 2.5-year-old lady, she presented with the precocious puberty. So she had breast enlargement from past 3 months. She had one episode of vaginal bleeding. She also had a LH of 0.07, FSH 10.2. E2 was 473 picomole per liter with prolactin of 156 nanogram per ml. She had TSH of 193, TPO was positive. She has the multiple small cysts, and MRI was suggestive of cellular mass. Why cellular mass? Because of the long-standing hypothyroidism, there is again negative feedback going to the pituitary gland. There is a proliferation of the thyroid cells, especially the TSH cells in the pituitary gland. So this was the picture at the presentation. She was presented by Dr. Bhantali in the 2009 published case. So after the diagnosis of hashimototheritis, she was found to have gonadotropin independent precocious puberty. So again, young girl coming to OPD with precocious puberty, thyroid examination is very much important, and this is the only simple thing that we can do, and we can treat with the levothyroxine, and we can see the again regression of tissues and regression of the mass in this one. So precocious puberty with cellular mass, so inappropriate progression of pivotal event suggests the diagnosis of gonadotropin independent precocious puberty. Childhood hypothyroidism is an important cause of GIPP, and poor growth velocity, delayed bone age are the hallmark for the hypothyroid associated GIPP. So MRI is recommended in all the children with the precocious puberty, because sometimes we get the other causes of the precocious puberty if it is gonadotropin dependent precocious puberty. So again, treatment is very much simple, levothyroxine. Third case, 19-year-old female who presented with acute abdomen, and she had unilateral oophorectomy on the right side. She was remained undiagnosed and untreated. Again, 1 year later, she had history of headache and vision loss, and found to have the cellular and supracellular mass. And she had short stature, dry skin, delayed tender reflex. She also have the normal perception of light. TSH was 1100, TPO positive, and again she had prolactin of 154. She undergone technetium scan, history of lingual thyroid. So lingual thyroid, that means again poor functioning of the thyroid gland. This is the mass in the seen in the pituitary gland, and what you can see the multicystic ovary on the left side, because right side was operated, and after the treatment she has the regression of the ovary tissue also. So again, simple treatment is that the patient, the multicystic ovary should again to go for the thyroid function, and we can prevent the progression of other diseases. So hypothyroidism and acute abdomen. So many patients also in OPD come to us with the SIO, that is subacute intestinal obstruction. So again, in those cases, now we have the available liothyronine, that is the LT3, and that is quite effective and very ultra rapid acting. So in that case of the if the patient is hypothyroidism, along with T4 we can give the T3 also, so that can relieve the patients very quiet. Fourth case is the 16-year-old boy who had history of short stature, again progressive increase in testicular sizes. So see, he has the increased somnolence and cold intolerance. He has the bilateral testicle volume of 25 ml. So we can see the coarse facies feature of the hypothyroidism, increase in testicular volume. And again he has the TSH of 1021 with TPO 160, FSH of 13, LH of 819, Puratin of 27. He started with the levothyroxine simple treatment, followed up after 1 year, height increased by 5 cm and testicular volume reduced by 20 ml. What happens in the hypothyroidism macroorchidism? So macroorchidism in hypothyroidism, because of the elevated FSH and TSH. So TSH, because it acts as again as the FSH over the receptor. This is the specificity spillover effect. So this results in the seminiferous tubular growth and proliferation. So after the treatment with the levothyroxine, there is decrease in TSH and also there is a decrease in the testicular volume, especially the reduction in the seminiferous tubule. So usually enlarged TSH should be prompt diagnosis for the hypothyroidism. Fifth case, again the patient is coming to with altered sensorium, we suspect for the hepatic encephalopathy. So again thing is that the patient is coming to with the postural dizziness or the loss of body hair. Patient has the low ECG complex, what we say the pericardial effusion. So patient again has TSH of 14.5 with TPO negative, and cortisol was 252 nanomole with ACTH of less than 1 picogram per ml. And what we can see the coarse facial feature of this patient and the cardiomegaly, and patient has the empty sella, that is the panhypopituitarism. So this was the case in we have when I was doing the my residency in the Chandigarh. He was the case I saw at that point of time, and he was again pericardial effusion workup found to be lymphocytic exudative effusion, and he was diagnosed with panhypopituitarism with TSH low, ACTH low, LHFS low, and GH low. Again he was started with the hydrocortisone 50 mg thrice daily, because when we started with the levothyroxine and patient is again the hypocortisolism, there is a further what we see that the hypotension or the dizziness is increased because the increased requirement of the cortisol at that point of time when the levothyroxine is started, and again other supplementation for the hormone were done. And what you can see over the follow period, you can see the effusion is reduced and come to the almost normal stage. But whenever there is cardiac tamponade, we need to go for the tapping. So how there is a pericardial effusion occurs? So TSH we know that is instrument for the GAG, that is the glycosaminoglycans. Again T4 is also slightly so to increase the GAG level. So replacement of levothyroxine leads to the resolution of pericardial effusion, and we can take the several months. We have the levothyronine which can reduce the pericardial effusion rapidly. Sixth case, the patient coming to the limping gait. So what happens in the hypothyroidism in the limping gait? Patient is also short stature, TSH was 162, and you can see there is a loss of head of the neck of femur in the patient, and this patient the pre-treatment and post-treatment. So limping will be improving, although not completely because of some patient's performances which are there for the long time. Seventh case is the poor scholarship performances, difficulty in getting up from the squatting position in 22-year-old boy, and he has the enlargement of the calf muscle. Again, feature of the hypothyroid were there. TSH was 662, and what we can see the patient core features, not enlargement in the thyroid gland, but we can see the hypertrophy of the calf muscle, that is the gluteus muscle. So not gluteus muscle, this is the so over the time what we diagnose, the patient is having the Hoffman syndrome, and there is a levothyroxine was started and 25 mg and increment up to the 100 mg per day. So calf muscle hypertrophy were reduced over the period of time. So this proximal myopathy also improved in the group of the patient. Again, eighth case is a patient of type 2 diabetes, 60-year-old lady, hypothyroidism. She was on the levothyroxine 100 mg per day. She came to us with the altered behavior, agitation and memory disturbances. So diagnosed to patient have the hematoencephalopathy. So hematoencephalopathy is again very commonly seen in the emergencies. So started with the prednisolone because there is a TPO antibody association with the hematoencephalopathy. So TPO antibody should be done even the patient having the suspected hypothyroidism with TSH is not so much high. Started with the 300 mg per day and later on given to the 100 mg per day. So again, prednisone was continued and given in the tapering doses. So hematic encephalopathy is diagnosis of exclusion, usually present with the episodic ultrasensorium, seizures, myoclonus, ataxia and incoordination. TFT is usually normal, but TPO title is highly raised. CSF analysis, EEG, MRI shows no specific abnormalities. Close differential diagnosis includes the CSF or myxedemous encephalopathy. So these are the steroid responsive encephalopathy associated with the autoimmune thyroiditis. So TFT and TPO should be done in patient with ultrasensorium of undefined etiology. Ninth case is the patient is having the metastatic cancer of the urinary bladder. Patient received the gemcitabine carboplatin. Now patient is the immunocheckpoint inhibitors, that is nivolumab. So again the immunocheckpoint inhibitors is affecting the endocrine glands, that is the pituitary gland, thyroid gland, pancreas gland also. So what you can see, the patient over the period of time had the rise of the TSH. TP was, you can say, not much high. So this group of the patient also we see there is an increase in the ACTH also affecting the adrenal gland. So ICPI related thyroid dysfunction, which is the typically due to the destructive painless thyroid gland or thyroiditis, spectrum may vary from subclinical to the overthyrotoxicosis and hypothyroidism also. So hypothyroidism is common than the thyrotoxicosis. So it is more common among the all thyroid dysfunction in the ICPI therapy patients. So presence of secondary hypothyroidism, a diagnosis of hypophysitis should also be considered in the patient taking the ICPI, that is the immune checkpoint inhibitors. It's a newer management for the carcinoma group of the patients. So now the last case of all the cases. So this came last year only, 41-year-old lady. She had history of dizziness, nausea, weakness and poor weight gain. History of postpartum hemorrhage 8 years back. She did not feed her last child also. Amenorrhea since last 4 years. Became fairer over 3 to 4 years. And she has the pulse rate of 48 per minute, which are regular. Blood pressure was lower side. Drop of the blood pressure again 22 mm in the standing after 3 minutes. She had TSH of 1.2, T4 of 2.0, which is lower side. T3 again lower side. She also has the low prolactin level, low cortisol level. And after the synaptone stimulated again, it was not more than 20 level. ACTH was again in the lower level. That is suggestive of the pan-hypopituitarism. She also had the osteoporosis because of the early menopause. So what you can see here in the MRI, patient having the empty sella. So secondary adrenal insufficiency, secondary hypothyroidism, secondary hypogonadism with hypoprolactinemia cause is the primary empty sella which is caused by the postpartum hemorrhage. So started with the again replacement with the other therapy like cortisone, levothyroxine, oral contraceptive pill, because you need to understand the role of the OCPs is very much important up to the age of 48 to 50 years, and again other treatment. So just concluding that diagnosis of hypothyroidism is not tough, but when to suspect, when to do, it is simply 250 rupees investigation charge. So we can go in almost in each and every patient if we can have the more detection. The hypothyroidism is second most common endocrine disorder after the diabetes. So it has the various clinical presentation from congenital to the old age, from congenital hypothyroidism to the hepatic encephalopathy, and threshold of suspicion for the hypothyroidism should be low for timely recognition of the disease. TSH, T4, TPO are sufficient for the diagnosis. Try to establish not only functional but etiological diagnosis is very much important. So sometimes we get confused with the T4, T3 and TSH. Last 10 minutes I will take just to look for the T4, T3 and TSH. This I will not going to discuss what are the prevalence and etiology of the thyroid. I have discussed with the cases. These are the few signs and symptoms. Not going to discuss. Yeah, these are some common difference between primary and secondary hypothyroidism. So primary hypothyroidism patient will be myxedemous and secondary will not be having some features. Headache, visual defect will be there in the secondary, not in the primary. Other pituitary hormone deficiency will be there in the secondary, not in the primary. Goiter will be there in the primary, not in the secondary. But in the secondary, get respect to the acromegaly with the hypothyroidism, we can have the goiter also. Cardiomegaly will be commonly seen in the primary, not in the secondary. Dyslipidemia in the primary, not in the secondary. High TPO can be seen in the primary, not in the secondary, and TSH is increased in the primary, not in the secondary. However, there is a logarithmic relation between the T4 and TSH. Whenever TSH is T4 is 1 point low, TSH has to rise by the 10 times. So logarithmic relationship is there between the T4 and TSH. So TSH is the primary to establish the diagnosis, and whenever we have the overt hypothyroidism, T3, T4 will be low and TSH will be high. In the subclinical cases, T3, T4 would be normal or TSH will be slightly high, you can say up to the 10. So again, there is a very much important role of the T3, free T3 and free T4. So whenever T3, T4 is low, patient having the normal TSH or suspecting the secondary hypothyroidism or TSH is high, T3, T4 is low, we definitely show the primary hypothyroidism. So whenever we doubt that the primary hypothyroidism is not or there or not, so we can go for the free T3, free T4. In pregnancy also, we can go for the free T3, T4 because what we see in the pregnancy first trimester, there is a high T3, high T4 and TSH is low normal. And we know the term gestational thyrotoxicosis is quite common in the pregnancy, especially in the first trimester. So in that case, you can go for the free T3, free T4. And if it is the TSH is slightly lower height with normal T3, T4 or free T3, T4, we know not to do anything for that cases. So this is the few conditions like TSH is 5 to 10, T4 is low normal, suspect for the early subclinical hypothyroidism and its progression to have the primary hypothyroidism, suspect in the central hypothyroidism or recovery from the systemic illness like patient was admitted in the ICU. So in that case also we can have such finding, we can again recheck after the 6 weeks. If the TSH is low, 0.5 to 5 with T4 is low, again central hypothyroidism will be in the favor, patient having the salicylate therapy or amiodarone therapy. If the TSH is 5 to 10 or T4 is more than 10, more than 12, so in that case again we can go for the free T3, free T4 because of the some hormone therapy like OCPs increase the T4 level. So before going suspecting this rare diagnosis of thyroid hormone resistance or thyroidopinoma, just go for the free T3, free T4 so we can have the normal value, then don't do anything and we can follow the patient over the time, or we can go for the TPO antibody. If it is the case with pregnancy, again we need to treat with the levothyroxine. So treatment is very much simple. Levothyroxine, hardly 150 rupees per bottle, and we can start with the low dose. We can increase after 6 to 8 weeks. However, in the older age cases, very much important. If age more than 60 years, start with the lower dose of 25 microgram, not more than that. And you can build after 10 days, 15 days, so that patient can adjust. Otherwise, risk of the arrhythmia or atrial fibrillation is also seen with the levothyroxine therapy. So timely administration is very much important. So many patients are taking in the night, patient taking in the morning, take the tea after that. So 1 hour gap is very much important, not to take any dhania pani or tea or whatever the patient is taking for up to 1 hour. And the gap with meal is very much important, and gap with the other medications. So like in the pregnancy, the patient takes the calcium, iron and thyroxine all together. So this is very much contraindicated. Thyroxine should be taken in the morning. Iron can be taken in the lunch. 6 hour gap will be there with the thyroxine and iron therapy. Then again calcium can be taken in the night because calcium and iron also interact with each other and they hinder their absorption together. So calcium can be taken in the night. So these are the protocol I follow in the pregnant lady, that thyroid in the morning, iron in the afternoon and calcium in the night, so that there is no interaction between all these 3 molecules which are commonly prescribed in the pregnancy. So in few cases like in pregnancy there is an increased requirement of LT4. So how is the target of LT4 in the pregnancy? So in the pregnancy, for the T4, the target is the 1.5 times of the upper normal range. So like the upper normal range is 12, we can keep up to 18 of the T4. However, if you are very much worried about that, we can go for the free T4. If T4 in the higher normal range, that we can satisfy with our levothyroxine dose. And sometimes this molecule, those molecules which increase the clearance by the CYP3/4 enzyme like rifampicin, carbamazepine, phenytoin, sertraline, and some molecule like amiodarone which block the conversion of T4 to T3, we need to increase the dose. Decrease the LT4 dose in the patient taking androgen therapy in the female like DHES or with the aging. Last 2-3 slides about the subclinical hypothyroidism, which are the how very much challenging. Sometimes the patient is having normal free T3, normal free T4 and increase in TSH. So I told there is a long linear relationship between the T4 and TSH and with normal TBG. So when to treat the subclinical hypothyroidism? So whenever the TSH is more than 10 and whatever the T4, T3 values, like if it is in the normal range or low normal range, we have to treat it. TSH with more than 5.4 with TPO antibody positive or having goiter or dyslipidemia or having anemia, pregnancy or any family history of autoimmune disease, we can give the levothyroxine with a TSH of more than 5.4 also. So these are the few things. So T4 therapy is recommended in this subclinical hypothyroidism in pregnancy, and whenever we are expecting to convert from the subclinical to overt hypothyroidism, all these are the few things. Or patient of the grave disease, or patient of the oral carcinoma, going for the radiation therapy, also look for the T4 TSH in the follow-up. So all these things from my side about the thyroid disorder. There are a lot of things to talk, but time is restricted for me. So I thank you so much for the invitation and for the giving you a wonderful time at so late in the night. Thank you so much.
What is TPO?
Sir, this is a thyroid peroxidase antibody. This is an enzyme. This is an enzyme that is important role in the thyroid metabolism in the thyroid gland. So this is the like antibody we look for this against this enzyme. So this is the like bystander. So whenever there is a autoimmunity, many of the beta cells going to act over, or we can say going to interact with this enzyme and develop the antibodies. So we detect the antibody against this TPO, thyroid peroxidase.